We've heard a lot about telehealth. To put it quite simply, it's nothing more than real time audio and video discussion between a patient and their primary caregiver. Years ago, it was a little more complicated. Telehealth kind of envisioned the real time patient telemetry going from point A to point B. So you had patients hooked up to a machine that was taking vital signs and downloading that data and sending it out to the provider on the other end. Luckily, we've gotten away from that. For me, I think there's still a place for or a need for having that type of data going to the person on the other end of a telehealth call. We'll talk more about, well, for example, before COVID, why did we have the limitations we had? Well, a patient had to go to a setting, right, to a physician's office, critical access hospital, health clinic, FQHC, somewhere where there wasn't necessarily a physician, right? Because if there was, you wouldn't need telehealth, but somewhere where there was some medical professional, even if that person couldn't write prescriptions or technically bill for a patient consult on their own because they didn't have their own NPI numbers. Nurse, paramedic were great examples of that, right? Now, you don't have to go to those settings, but I still think it's important that that patient information be gathered by a healthcare professional beside the patient. And for EMS, that's clearly where we fit into that picture. So instead of having just a patient at home, now we've got a patient at home with still a medical professional there at the patient's house, able to give a little bit more detail, right? Take temperatures and blood pressures and pulse ox, the things that the physician on the other end or nurse practitioner, whoever it is, would like to know about the patient, but the patient wouldn't necessarily be the best historian or communicator of that information, right? So we've got an opportunity with telehealth to be a solution in an area where we've specifically kind of backed away from that old requirement. Now there's more types of services that qualify for telehealth visits, right? We had a fairly short list, but now home visits, even initial ED visits, nursing facility discharges, therapy services, all can be done via telehealth. So it's expanded, not just in the scope of what we can do and where we can do it, right? It doesn't have to originate at one of those facilities any longer. It can originate at the patient's residence. It doesn't have to be limited to rural areas. That was another huge hurdle for telehealth. It was really focused on those health provider shortage areas and making sure that we could get patients access in those areas. But now that we've got these three major changes, it really has opened the door up. And I don't think it's going to be temporary, right? I think this is, a lot of things are tied to the PHE, to the public health emergency. Don't think this is one of those. I love this quote from the administrator of CMS. I think the genie's out of the bottle on this one. I think it's fair to say that the advent of telehealth has been just completely accelerated, that it's taken this crisis to push us to a new frontier, but there's absolutely no going back. Sounds pretty unequivocal, right? So I think telehealth is here to stay. And the question is, what's that going to do for EMS? Well, it's going to affect call volume. It's going to affect the options that the patients have, the options that we have to offer the patients. So there's going to be fewer emergent trips and non-emergent transports. So with that said, what can we do to help? And I think that reducing ED overcrowding in the age of, well, and feel free to chime in on this one. I've had clients tell me that they've had a crew go through an entire shift on the wall at a hospital. So 12 hours, for example. We certainly would like to see telehealth and alternate destinations moving patients out of those overcrowded ED wait times. And let's face it, which are the ones we get stuck with on the wall the longest? The ones that are the lowest acuity, right? The ones that really probably don't need to be in the ED to begin with. If we can impact those ED wait times and those ambulance patient offload times by offering telehealth to patients, then I think it is not just an area where we can maybe see a direct financial impact, i.e. a payment for the service we provide, but a way to help reduce losses. So internally, I think there's value to us, even if we didn't get paid for it. So if I've convinced you that telehealth is here to stay, or maybe I didn't, maybe the administrator of CMS did, and patients are really electing to use it, then what can we do? So with all that said, I really do want to hear from some of you guys about your experiences and what you're seeing work. If you've gone through the process of jump in. Randy, do you have something to say?
We may want to make sure
that. Excuse me. Oh yeah, he went away. Okay, I guess Randy was not ready to chime in with us. He was just accidentally unmuted. So, but unmute yourself when you do want to chime in.
Hey Chris, this is Tara from Amerimed.
Hey Tara.
Hey, so we just started using this exact same model. Our traditional model encompasses a nurse practitioner and an MA. And we recently hired a community paramedic, and we are eliminating the need for the MA to go with her. The model is working pretty good, and honestly, it's allowing the community paramedic to work more autonomously and using their full scope. Some of the things that I hear in my community paramedic programs is I feel like I'm a medic again. I feel like I'm really making a difference in the patient's life, and the patients are very receptive to having a paramedic in their house and allowing us to provide that mid-level care via telehealth or that full patient continuum of care. So it's working well for us, and we're growing and expanding. And I just got off the phone with another organization in South Georgia who are interested in this. So the word is out, and you're right. We're never going to go back. I think this is the future. I've been saying this for a long time. To be able to provide all level of care on a scene with somebody there is so completely different than allowing a patient to sit in front of a screen.
Yeah.
That's all I wanted to say. Thanks.
No, a couple of excellent points. First, reiterating what I was trying to say, probably not very articulately earlier, but to have a patient initiate a telehealth call on their own with no way to take and understand some of those vitals is it's limiting. If we're there on site with the patient, I think it gives the patient ultimately a better experience. It gives the qualified healthcare professional on the other end of the call more accurate and important information that they need to make their clinical decisions. And it's going to just be a better experience for the patient, right? They're going to be a lot more comfortable with the overall encounter if they've got some help on their end and they're not just left to their own devices. And also, I think it does provide our crews with not necessarily a level of assistance that they need. I mean, I think we can function on our own, but it sure is nice to have the other set of eyes on the patient, the set of eyes from the other end of that telehealth call. We talk a lot in mobile integrated health about having good protocols. because we're putting our folks out there into new circumstances that they may not be familiar with from past work as a paramedic or even EMT. Having good protocols kind of helps them to be comfortable in this new role. I think telehealth really does assist with that process, right? It allows us to have that other coach in the room, right? So I think from a patient perspective and from a EMS provider perspective, there's a lot of benefits to telehealth. And of course, then the question is, how do we get paid for it? Because it's nice to provide that level of service for the patient, but it's also really nice to have funding models for that. And CMS has said specifically that, hey, telehealth providers, the qualified healthcare professional on the other end of the call, can absolutely partner with ambulance services that are on the patient end of the call when they're delivering that telehealth encounter, basically in two places, with the patient and with the QHP. Yeah, this is what they said. The physician can enter into a contractual arrangement, including with entities that furnish ambulance services, that can provide the staff and technology for the telehealth. So they're saying, hey, healthcare provider, you can contract with these ambulance services. You can pay them for their on-site, the value that they're bringing to the encounter from their on-site services. But what are they paying us with? Well, they're paying us with part of their QHP fee, right? Part of their origination or destination site telehealth fee. And believe it or not, there's not a lot of money in that bucket. So yeah, they can share that with us, but there's not that much to share. So it's probably not going to be enough to justify our crew and our staff time there with the patient, but it's certainly one piece of the puzzle, right? We don't have to get all of the money from the encounter out of one bucket. And if you think about it, that's really the way healthcare is operated forever. The patient may be responsible for part, their insurance may be responsible for part, maybe a facility or another healthcare provider may be responsible for part of the expense. So that's not really that unusual for us. If you think about it, it's just a new way of looking at that same old problem.
Hey, Chris, this is Rob. Can you hear me?
Yeah, absolutely.
Perfect. Hey, great. I've got 7 different kinds of technology going on. Hello to everybody. First, my question is I'm 100,000% for this, and I'm just trying to figure out what kind of different models people are using, because I'm still tying up a truck, right? I'm still going to tie up a truck I'm seeing that's doing telehealth. They could be there for a while, if the doctor can't break free, or if they don't have a dedicated physician in the ER that I'm working with to do the telehealth. And then we're going to do the vitals. We're going to explain everything to them. I would probably say we may have to at some point take them to get a prescription. So are people thinking of using on-shift crews and on-shift ambulances? I've got 5 in Newberry that are on shift all the time. Or are we going to try to shift it or encourage or look at, because my feeling is this: I set up a QRV that then takes my alpha and omega level calls, my really, really low acuity calls, and that's my telemedicine truck, because I can't afford to take a truck to just sit there for that long, especially if we're not going to get paid for it, no offense. But if the payers aren't going to come on board and pay part of it from the insurance, and the hospitals are going to give us $25 a call, I'm just trying to figure out what model works to where I'm not taking a unit or 2 out of service doing telehealth and then busting out a big bus wreck somewhere. So I'm trying to figure out what people are doing to sort of acclimate to that, because if you're not going to get walled out at the hospital, now I'm going to get walled out in somebody's house, waiting and talking to the doctor and doing the telemedicine. I think this is a great thing, but I need to figure out how to get paid for it so I can add that additional crew or that additional QRV to do the telehealth on the really low acuity calls. Is this making sense?
Oh, absolutely. And I'm going to open this up to everybody, so kind of be thinking about your answers, folks. But I think that's a really important point, because it does depend on the payer as to what level of service we're going to be able to provide. For example, with the telehealth piece, if we're only getting paid by the qualified healthcare professional sharing part of their fee that they get for the telehealth call with us, and then the remaining balance basically being shouldered by the patient, well, we could do that with an SUV and a telehealth crew, as you put it. However, if we want to bill it as a patient encounter, with most insurance companies, that requires an ambulance response. So, for example, the biggest one I can think of is Anthem Blue Cross, because they're paying for treatment without transport in something like 14 states. So when they came on board and said, "Hey, we'll pay for this," well, that's going to be an ambulance response. I don't think they've ever said we'll pay for a different type of response as long as you do treatment on scene. And certainly with ET3, I think that's probably one of the biggest short-sighted points of ET3 is
Right.
they require us to, or allow us to do treatment without transport, but they require an ambulance response still. So we're still expending
Right.
that money. But no, great question. A lot to unpack there. So let me open up the floor and see what other people's experiences have been on this.
So I actually have a little something to say on that. Let me turn my thing on. So I know that in the past there's been conversation about how insurance reimbursements have been very limited. However, and I know this because I just had a conversation yesterday with them. There are private companies that are beginning to work exclusively with insurance companies to go out to physicians in whatever region that they're servicing, and they're reimbursed wholly by the insurance company as part of the actual visit. And so they're not going out in ambulances. They're not even going out in QRVs. These are full-time employees who work for the company, who utilize their personal vehicle, so they're reimbursed for mileage and whatever, paid an hourly rate, and they are not part of the 911 system. They're a private entity that works exclusively as a contractor for the insurance company. And if what they're paying their community paramedics is any indication, they're making money. They're making a significant amount of money doing it. So I don't know how that, and I'm not a lawyer, I don't know how that would translate into a government entity or a county-run EMS service being able to do something like that. But I would most certainly think that if a private entity can do it, that you would be able to do it too. I can talk to them more to figure out how they work with the insurance company to see how that works. That's the first that I even heard of that. But let's put it this way: they started out in Montana, and now they're in 10 states.
I think you may have broke up on us there for a minute, Drew.
Can you hear me now?
Yep, you're back.
What was the last thing you heard? I'm sorry.
I couldn't tell you.
Montana and they were started in Montana and went
Oh,
to 10
okay.
states.
All right, thank you. No, yeah, it's that was pretty much it. They started in Montana, and now they're in 10 different states as private contractors. And so obviously they're doing something right. So I'd be glad to speak with them further just on the concept of how they, how they work with the insurance company to make that.
Why does it smell a lot like hospital at home without the hospital involved?
I mean,
well, there's several agencies out there, .go, Dispatch Health. There's a third one that I recently saw come up that are about that same size. So there are several.
Yeah. I mean, this company is owned by 3 paramedics. So, I mean, it's, they started this on their own, and they're making enough money to branch out into different states just by working with the insurance company. I don't see why anybody else can do that.
Well,
Thank you for that, Drew.
This just in, I think the next quarterly meeting will be our special guest speaker will be Drew Ross bringing us more information about these exciting new options. Oh, sorry, Drew. Didn't mean to put you on the spot.
Oh boy.
Second motion.
What was that?
I second the motion by Chris.
But I mean, that's all kidding aside. This type of collaboration is exactly what I was hoping to get out of this session. That's good information. So thank you, Drew. And anything else you can bring us on that, any further information would be, I'm sure, much appreciated.
Well, as the association, I mean, that's really, we want to be able to act as a resource. So, I mean, if we know of options out there.
And that's actually a really good segue to the next slide I got up on the screen about dotting the I's and crossing the T's. One of the things that we have to be careful for or of as we're implementing innovative new types of models for MIH is making sure that the state laws and rules and limitations keep up with the changes in what we're actually doing. So make sure that that's something you consider before you branch into anything new. Check with your state EMS office, your local council, and make sure that treatment in place or transport to alternate destinations is something that is anticipated and allowed by your state rules, because otherwise we can get sideways of not just the state office, but of patients as well. If something goes wrong and we didn't technically have the legal ability to do what we were doing, then we don't want the patient trying to hold that against us, is basically what I'm, the moral of my story. So make sure that you're taking that into consideration. We've already touched on ET3 a little bit. ET3 looks at things kind of from the perspective that the public health emergency has shoved the rest of us into anyway, right? So ET3 went from something that was kind of a theoretical thing for a couple of hundred agencies that were interested to be involved in as a model to, well, now everybody can do treatment without transport because we can do that treatment in place protocol according to Medicare. We can do transport to alternate destinations all of a sudden. So ET3 almost got rolling and antiquated at the same time. So it's been kind of interesting to watch how the public health emergency has really changed how everyone views EMS. We talked about who may be on the other end of that call. Basically, it's going to be anybody that can bill independently for the patient encounter. So anybody other than a nurse or a paramedic. So physician, nurse practitioner, physician's assistants, clinical nurse specialist, or nurse midwife. All these folks are going to be independently enrolled and have their own billing privileges with Medicare and commercial insurance. So they are considered qualified healthcare professionals for the other end of that telehealth encounter. Working with these folks, it's a good idea to have a contract. You want to make sure everybody's on the same page, what limitations, what expectations they're going to be. As a lawyer, I always tell folks, I wish I could think of every possible permutation of the relationship between two parties when I draft a contract, because if you could think of everything and go ahead and address it in writing before the relationship even started, you'd have a good relationship. It's those issues where there isn't a meeting of the minds, where one party doesn't know what to expect of the other, that creates hard feelings. So good contracts do help to build that relationship and keep you on a good, solid foundation. As a funding model, we talked about working with your QHP. That's certainly not the only pocket for us to look at. Anybody have any experience with these facility readmission programs? The readmission penalties for CHF, heart attack, pneumonia, chronic lung, or bypass surgery are significant. I know some of these facilities are willing to eat these penalties. But readmissions definitely are a kind of have always been a catalyst for mobile integrated healthcare providers to have some kind of funding from their local hospital. So has anybody got any positive or negative experience with working with these readmission programs, and kind of what are you seeing as a funding model? Is it sufficient to help us fund MIH?
If she'd be willing to speak on it again, but I really found what Victoria was sharing down in Atlanta to be very interesting as far as we make a lot of times when we go to the hospital or to make our pitch for, you're going to save this amount of money over a period of time. She was able to offer the other side of that argument that you're being too effective. If Victoria's on here, I would really like her to chime in on that, because that's a to me that was something I had not
That's
dealt
Summer.
with.
Oh, there she is.
I'm
Come on.
here. I'm here. Yeah. So, and I don't mind, this is an unpopular opinion, I think, and health systems may not love me being candid about this always. But the hospital readmission model is founded on this concept that hospitals are being penalized for readmissions within 30 days. But it's not usually a substantial penalty in the way that we're all thinking. So, the example that we discussed at the MIH Summit is that if a hospital gets paid, 20 grand for every hospitalization for a patient, then the next time that patient is hospitalized, they might suffer that penalty. And this time they might only make $17,000 or $18,000 or $19,000. And so it is less revenue for the second hospitalization, but it's not like a huge penalty like we're all thinking. And those numbers aren't exact. That's just kind of an example of how you really should be thinking about hospital readmissions. Now, hospital readmissions are a hot topic, and they relate to, Medicare ratings, and a lot of other things come into play when we talk about hospital readmissions. But the bottom line is that if we totally prevent all additional hospital admissions, then we're costing that hospital 17 grand or 18 grand, right? So they're not making the full 20 this time. They're making a little bit less than that, but it's still additional revenue. And so you want to be effective in reducing the hospital readmission rates below the national threshold, so that hospital doesn't look like they have poor processes in place and they can maintain the degree of reimbursement that they want. But ultimately, if you're too effective, right, then that hospital does see a reduction in revenue. And so this is where it becomes a balance between PR and an actual revenue coming in. So the hospital readmission model can be a successful approach, probably on a smaller scale, maybe. I don't know if anybody has any other thoughts to add to that.
Well, and I think going back into what I was just talking about with the targeting of, I'm sorry, not targeting, but the contracting with the insurance companies. I mean, for the longest time, the conversations that we've had about reimbursement has centered around going to the hospital and saying, we're going to be able to drop, or to increase your reimbursement rates, from your readmits. But you bring up an excellent point, and so I think that's one of the reasons why we're beginning to see more of the willingness of the insurance companies to come in and say, because to them, it's definitely, there's no positive way they can spend not or having to pay out too much money continuously for patient care. And so if they can contract a CP, to whether it's they're paying them directly or whether they're contracting with the county organization or whomever, I mean, to them, that's nothing but beneficial.
Yeah,
And I would like to see us as an organization really lobby for that. I mean, to push for that, because I think that's going to be, if you're
Oh, I think he's breaking up again. I
Yeah.
know, Tom, I don't know if you or anybody else from a health system perspective might have some general thoughts.
Yeah, absolutely. I will definitely agree with what you're saying. You going back to, the MIH summit and the presentation I did, Henry Ford in 2019 had 5.4 billion in revenue. We had 1.6 million in penalties for CHF. So the health system kind of looked at that and said, eh. But at the same time, if you look at other penalty areas, such as COPD, that's where we really got struck hard. So it's important to be able to have that communication, have that discussion with these health systems. Where is it that you're really concerned? Where are you struggling? And we may be able to help in that region or in that area. Coming from the payer side, because obviously I work with our payer as well, that really, as Drew is saying, that is an area that is untapped, and really those discussions are very beneficial to have, because it's really the payers, the commercial payers are the ones that are going to say, hey, you could save us some money here, that we'll most definitely work with you.
Yeah, that's the slide I have up now. It's all about following the value, right? You look at what value we bring and who it is that's really receiving that value, and you work backwards from there. And a lot of times that will be the payers.
Yeah, absolutely. And I think you're going to have a benefit to both sides, of course, but the payers are the ones that really have not been reached out to very much across the board from what I've seen.